Good evening. يسعد مساكم جميعا. الآن بروفيسور ساهر صبري تفضل.
Good evening. We are opening our evening session, second session for today, with inviting Dr. Saher Sabri. Dr. Saher is the Chief Interventional Radiology for MedStar Health and Professor for Radiology at the Georgetown University. He will give us talk about embolization for postpartum hemorrhage. Welcome.
شكرا دكتور. السلام عليكم. So I'm the not OBGYN in the rooms. I'm the interventional radiologist. So thank you so much for the invitation. This is my second time at this conference. Remember in 2019, this is when we had the first meeting. So it was great memories at the time. Thank you, Dr. Sufyan, Dr. Nihad, for the invitation. So I'm going to talk about postpartum hemorrhage, embolization, and just the role of what interventional radiology can provide. And we heard earlier talks about the issue of postpartum hemorrhage. So you all know this information, the definition of postpartum bleeding, and it's definitely increasing, and it's a major issue, with maternal death. The definition is loss of 1 liter of blood within the first 24 hours, regardless of road delivery, plus signs of symptoms of hypovolemia. And that's a definition. Usually it occurs in the early PPH occurs in the first 24 hours. And the most common cause is uterine atony, and that's the major issue that we deal with. And then you have the lower genital tract lacerations. Less common causes, which of course happens more commonly nowadays with the high C-section rates, the Akrita spectrum, and some coagulopathy. So, for conservative treatment, which is what all of you are experts in, and there's going to be a talk later on tomorrow about this topic and how to do appropriate fluid resuscitation, managing the hemorrhage with transfusion, and administration of either tonic drugs and tranexamic acid as options for treatment. And of course, all the other aspects such as uterine massage and packing and balloon tamponade. So all of these are conservative management that you all know. And this is a very good review in New England Journal of Medicine about the postpartum hemorrhage, and has the these 3 areas of when the blood loss is liter to a liter and a half versus liter and a half to 3, and most of it is a conservative management. I want to direct your attention to when the loss is more than 3 liters. And that is when the role of interventional radiology should be considered, which is uterine artery embolization for these patients. And I just magnify this. There's some major options such as bilateral ligation of uterine artery, of course hysterectomy as a last resort, but definitely uterine artery embolization should be considered before some of the radical aspects such as hysterectomy in especially young patients. So when can we, participate as interventional radiologists, especially in hemodynamically stable patients with refractory postpartum hemorrhage, also unstable patients, and there's some, ways that we can do it ahead of time with surgical management, especially for patients with Akrita, and I'll talk about that in the end. So I'll start with the first part. So uterine artery embolization is a procedure that is being done routinely. The procedure is very well refined, usually done from a femoral axis or from a radial axis. We actually did a procedure today at the Maqasid Hospital. We did an embolization for a uterine fibroid with Dr. Al-Zaghal and Dr. Abu Sharq. So it was a 45-minute procedure, very quick to do. So this is something that we can use as a rescue, and it's an easy procedure to do. And things that we look for is extravasation, pseudoaneurysms, and truncation of the artery. So as long as the uterine arteries are present and accessible, you can easily get into them by catheterization. And we use several particles such as gel foam, which is transient, or more permanent like particles, like it's called PVAs, alcohol type medications. And this can be repeated, and this is something that we've done and you can do it for both sides. So what do you do when you have postpartum hemorrhage? How do you manage it? So when we have a situation where there's it's refractory to medical treatment, especially after vaginal delivery, then what we do is we bring the patient in, we do an angiogram. We rarely see a specific abnormality like extravasation or pseudoaneurysm. So basically, we just empirically embolize both uterine arteries with gel foam. And gel foam is resorbable and basically recanalizes after 2 weeks. So this is something that is safe to do. And I'll talk about what that means and what the complications could be from it. But it's a very quick procedure to do. And you puncture one side, and you go and catheterize both uterine arteries and inject gel foam. And it can be done quickly. Sometimes when the source is not known, you can do a CTA to see where the bleeding is. And you see here there's a pseudoaneurysm that is in the lower uterine segment. In that case, we did an angiogram, and you see the pseudoaneurysm. And for these, you can put coils and basically exclude that pseudoaneurysm that was bleeding. And sometimes you may have to assess collateral flow, such as from the ovarian artery or the round ligament. And sometimes there could be bleeding from there. This is a case where there's bleeding that was, both from the the ovarian artery. You see this big tortuous artery. This is an angiogram of the aorta. You see a big tortuous artery. So that was contributing to the bleeding. And on here on the left side, the left uterine artery, you see major pseudoaneurysm with extravasation. So this is really hard to control any other method, and it's very easy to do with embolization. Basically, you put a little bit of gel foam, and that will take care of it, and it takes a few minutes. And this was done similar for the round ligament artery, was bleeding, and that was treated with gel foam as well. So the technique is well studied and refined. So some patients who we may have to do, if there's ligation of the uterine artery, procedure becomes much harder. And this is something that we always discuss. If you run into issue of a major bleeding, especially during C-section, ligation of the uterine artery is one of the rescue methods that can be done. The problem with it is if it doesn't control it, then the procedure to embolize becomes much, much harder. And we've run into this issue many times where you go in and there's no uterine artery to embolize, but they're still bleeding through small collaterals, and these are much harder to catheterize. So this is a discussion that is to be had in the institution. If they have capabilities to do uterine artery embolization, it's a much easier procedure to do when the uterine arteries are open and much harder to do when the uterine arteries are ligated. So, and you have now to go through collateral. So this is something that we always discuss with our OB colleagues. The success rate for embolization for postpartum bleeding is ranges between 79 and 90%, and sometimes you may need a secondary embolization, and success for that is in the 80% range. Now I want to talk about a secondary causes of postpartum hemorrhage, so patients that come later on, after between the 24 hours and 6 weeks. And for these patients, usually it's return products of conception or it's AVF. And sometimes you can't tell which of the two. Is it an AVF or AVM, or is it retained products? And you can do it by, you can take a look by ultrasound, and you see the findings within the uterine cavity. And sometimes you can do MRI, of course, as a beautiful finding that you can see. But of course, ultrasound can show you what you need to see. And for these, again. If there's a concern about an AVM, embolization works very well because of risk of curettage and bleeding from there. So there's always a good discussion about it, and if there's a thought that this is most likely an AVM rather than a retained products of conception, then we can do an embolization, and again, it's a similar procedure that is done. It can be done late, within 2 weeks or later after delivery. So this is another case of a patient who had an AVM and that was embolized afterwards. So the other aspect I want to talk about is that CREDA spectrum. I think Dr. Martha mentioned this earlier about the rate that has increased significantly because of the high rate of C-section, especially in our area. And what we need to do. So you all know that CREDA spectrum, that CREDA, INCREDA, and per-CREDA. Of course, the worst is the per-CREDA, where there's complete invasion through the wall. And these are the ones that we really were worried about, especially if there's involvement of the bladder. And this is the lower uterine segment is, as you can see, has the bulging placenta. And of course, you all know the risk factor for it. And of course, the more C-sections you have, the higher chance that you're going to have an CREDA spectrum. And of course, the risk of bleeding, ICU admission, infection, and of course, in surgery, injury to the bladder or the ureters. So the idea is it better to embolize or to deal with this on an elective or emergent basis? So, usually, incidentally found placenta accreta of time delivery has a high mortality and morbidity. And, trying to do a hysterectomy without prior embolization can have significant blood loss. So it's important to have early recognition and diagnosis. So how do you diagnose? Ultrasound works very well. A lot of these patients have low-lying placenta and previa. You can find lacuna and turbulent flow. And myometrial thickness of less than millimeter may also be seen. So these are some of the findings that we see with a bulging and abnormal placenta close to the bladder. Of course, MRI is definitely an excellent method of finding abnormalities, especially if you use gadolinium, and sensitivity is very high, as up to 88%. And you look for findings such as hemorrhage signal within the placenta, and then loss of differentiation and urine bulging into the bladder. And here you do it with a full bladder and without a full bladder, and you see a low-lying placenta. And then on this coronal image, you'll see that there's loss of differentiation between the placenta and the bladder and invasion of the bladder. So going into this case ahead of time, you know that this is what you're dealing with, and then the planning for it becomes easier. So so there's some studies looking at what can you do. If you know you have a placenta accreta, what can be done? So there's several studies that have been done, some of them of putting balloon catheters inside the internal iliac arteries or before the procedure. So the patient comes in to the angio suite and they put catheters with minimal fluoroscopy, and then they go for their treatment. And then if there are any issues of bleeding during after delivery, then they can come back to interventional radiology for embolization. So that is a process that's been discussed. And some consider a combined procedure, such as doing it in a room that has fluoroscopy, and you can do delivery, the C-section, and hysterectomy if needed, done at the same time. Of course, there's discussion about using the Roboa catheter, which is an aortic balloon that can be placed and inflate the balloon in the aorta. And that has been discussed in the literature as well as an option. And this is a hysterectomy with patient after embolization. So there's a study looking at can you do these scheduled cesarean hysterectomy and doing it in a controlled circumstances. And this is a study of 76 patients and doing it in a controlled circumstances. And trying to avoid removing the placenta before embolization. So the process goes that you get ready for the embolization, you do the C-section, and then leave the placenta alone, and then do the embolization, and then remove the placenta, and if you need to do hysterectomy at the time. So the idea is not to try to remove the placenta without embolization. So this is some of the cases from our center. And looking at some of the patients who were done without prior embolization and had up to 54 units of blood, and some of them were done when embolization was done and had very limited blood transfusion. So so planning it would work very well. So how does that work? I'm just going to go through the process that we have at our institution. The patient starts in interventional radiology. We place occlusion balloons, but we leave them deflated. Then the patient goes to the OR for C-section, and then we inflate the balloon. Then they try to remove the placenta gently, and if it comes easily, then that's it, it's done. But if there's any issues with the placenta, then it's left in place, and the patient goes to interventional radiology where they get the embolization, and then later on, they complete the last part of the procedure, whether it's removing the placenta or doing hysterectomy. So that is the process that we work through, and this is documented in the literature as a process, and it can be done at two different places. Do to IR, go to the OR, then come back to IR. We're blessed that we have a hybrid room where there's a fluoro suite inside the OR, so we do the same procedure. The whole process happens at the same place, and there's no need for the patient to transfer. So I'm just going to show you quickly. This is the angio suite with the room, and this is done in interventional radiology. So It doesn't need to be, depending, on the surgical exposure that is needed. And these units can be done and can be, the interventional radiology suites can be equipped with OR equipment. So this is the process. We have a NICU setup and everything is ready. This is the back table that have all the embolization material that is needed. And then here we have occlusion balloons into each side from both axes bilateral, and we put the occlusion balloons. And then we do the, get ready to do the placement of the balloon first. And we use a very low frame rate so that we do not have any effect on the baby. So these are the occlusion balloons being present. This is, you see the baby, very low flow rate. And then afterwards, we do the angiogram after the C-section before the placenta is removed, and we do the embolization. So this is, embolization on one side, embolization on the other side. And once we're done with that part, then hysterectomy is done. In this case, the patient needed hysterectomy because of invasion of the bladder. And then after that, we do another angiogram before the patient gets off the table before closure. So this, has a very good effect. So quick question about fertility, after embolization. And it shows that, there's a decreased rate of future pregnancies, around 55% versus patients 93% who did not have embolization. But this could be because of the postpartum hemorrhage or because of the embolization. We don't know. But it's definitely something to consider, and comparing it to the other, aspects such as ligating a uterine artery or hysterectomy. And in terms of other complications, usually they're very well tolerated. Just some buttock pain. Rarely could be some uterine necrosis and things like that. They are very reported. So the role of IR is to try to help with cases that have difficulty with bleeding and difficulty control. And fertility outcomes indicate that they can resume menstruation and there's a reasonable likelihood for future pregnancy. Thank you so much.
شكرا دكتور صبري، محاضرة قيمة وجميلة طلعت.